Hi, I'm Dr. Jonathan Clark, and I'm a board-certified chiropractic neurologist, and I'm also a member of the International Association of Functional Neurology and Rehabilitation. What we're going to talk today about is about peripheral neuropathy. I've talked to a lot of patients in my office, and they say, well, I've been diagnosed with peripheral neuropathy. I don't really know what it is. I've just been given some medications and told to live with it. Well, hopefully this will provide you some insight about what makes us different and how we treat this condition. And I'm here to tell you that no stone is going to be left unturned for us to determine exactly what's causing your problem. So when we deal with chronic health conditions in our office, whether it's fibromyalgia, vertigo, sciatica, reflex sympathetic dystrophy, chronic neck issues, rheumatoid arthritis, they'll have some common thread involved, or something that's similar with all of them. Basically, there's usually an oxygen deficit, there's some neurological misfiring, there's definite metabolic imbalances, such as blood sugar, cortisol problems, adrenal issues, possibly even anemia. So the way we handle peripheral neuropathy is really no different than the way we handle any other chronic condition in our office. We treat it both metabolically, we treat it both neurologically as well. Depending on the individual tells us how much one is involved more than the other. So the prognosis of peripheral neuropathy really depends on my ability to fully understand what's going on here, and for us to determine how much is metabolically, how much is neurologically, and to properly diagnose the nerve fibers that are involved in your case. There is hope with this, folks, and that's what we're going to talk about today. Okay, so most of you have been diagnosed with it, but that's about it. Really don't know much about it, have just been told to live with it, maybe given some medication to cover up the problem, tried some orthotics. That's a common approach. And again, the same approach I take with peripheral neuropathy is the same thing I do with any other chronic case in my office. So if we can address the cause of what's going on here, then we have a chance at correcting this problem. Again, something only goes away when whatever's causing it goes away. And the key to remember with this is that peripheral nerves regenerate basically an inch a month if you give it what it needs to heal and survive. So for some of us out there that have chronic problems where the whole foot may be involved and it's starting to work itself up the ankle, or maybe in another extremity in the fingers, you got to multiply those inches by the amount of time it takes to regenerate that nerve. Some of us it takes a very long time, folks. So keep that in mind, 1 inch a month for regeneration. So the basics of peripheral neuropathy, well, there's a problem with the nerves that are carrying information to and from the brain and spinal cord. So basically the message is from here that goes down the spinal cord into the extremities is not getting through properly. So it's kind of like talking on a telephone, and somewhere in between you and the other person the connection's being disrupted. The symptoms depend on really which nerves are affected. There's a sensory neuropathy where you feel pain, which is primarily the majority of neuropathies. There's a motor neuropathy where you actually have problems moving those affected limbs. So we know that if there's a sensory problem, it's going to result in feelings like hot and cold issues, painful touch, pressure, vibration. It can be tingling, prickling, or numbness. Oftentimes it's a common thing to hear of a sharp electric pain or a burning. Inability to determine where your feet are. Folks, that's one of the reasons this is so very important, is because once we start to lose the feeling of our feet, we can't determine where we are in space, hence the reason we have more falls and trauma. So this can be very detrimental to you. So again, obviously damage to the motor nerves leads to inability to move those areas, weakness in those areas as well. So it's an extremely dangerous condition, and we really shouldn't take this lightly. And we've had patients in our office that have said the exact same thing, that they can't even get to sleep at night. The pain on their feet from the covers causes discomfort. It's affected their ability to do things they like to do. They can't get out and spend the activities with their family and friends that they like to do anymore. This can lead to structural damage, atrophy of the muscle, poor healing, again, slips and falls. This can be debilitating. So we need to understand what controls and coordinates all functions in our body. It's really via the brain, the spinal cord, and the rest of the nerves that emanate out from that area. So again, we have the brain that tells our spinal cord, that tells the body what to do, and it sends a message down through the spinal cord and then out the roots. So for example, out of our neck into our shoulders and fingers. It's the same way in the lower extremity. All those messages go down, and the input has to come back up as well. So there's a constant relay of information going back and forth between these two areas. So if there's an interference in the relay system, how that happens we'll talk about, then obviously the communication is going to get messed up. It's going to lead to those things that we talked about earlier, the pain, the discomfort, the inability to move. So the body really needs two things in order to be healthy. Okay? It needs fuel, which comes in the form of the food we eat, such as glucose, and the air that we breathe, such as oxygen. And it needs activation. Activation is kind of like exercise for your nervous system. We are receptor-driven individuals. What that means is your body and brain constantly thrive on the stimulus it gets from its external environment. So when we alter that stimulus, when we stop walking as much because our feet hurt, when we have chronic pain in an area, that's going to affect those areas in the brain that control those responses. Okay? For example, there was some research done with some college students, because college students will do just about anything for money. I think we all know that. So what they did is they divided these college students into two groups, and they took some imaging of their brains. So for example, they took some imaging of the right side of the brain. This area up in here is called your parietal cortex. That's your sensory cortex. So on our right side of our brain, our parietal cortex controls the left side of our body as far as sensation. So if I push on a pinprick on my foot or my finger on the left side, it's felt up here in the right parietal cortex. So what they did is they immobilized these individuals from the waist down on the one side. So the left leg was completely immobilized. And then they did obviously nothing to the other group, because that was the control group. 2 weeks went by, and then they measured these tests again, and they found that the group that they did nothing with, obviously there was nothing different in the brain. But the group that actually had the mobilization, they already showed signs of degeneration or decreased neural activity in that area of the brain. This is within 2 weeks, folks. Think about your condition and how long you've had this. What do you think this has done to your brain, excuse me, long term? When you chronically can't feel things, or you're chronically getting bad sensation input into the brain, it's leading to problems down the road, folks. This is causing problems with the brain to degenerate or neurally deactivate prematurely. So there was some research done, again, in fact this was in Newsweek a few years ago, but it talks about rewiring your gray matter. So what it means is basically this. The brain is not a plastic structure that we used to think it is. It's something that can be molded, that can be changed, and it's all based on our experience. And there was a doctor, Dr. Taub, who figured a lot of this stuff out, and what he did was he was taking stroke victims, even that have had strokes and inability to use their extremities for years, and he was making them use those weak areas. So, in other words, if we have a stroke on the right side of our brain, our left side is going to be affected. So instead of him saying, okay, you know what, we're just going to make you use your right arm, forget about that left arm. No, he was physically making them go and do more activities with that hand to change and increase the integration in that side of the brain and make do of what they had left. So if you give a nerve what it needs to survive, which is fuel and activation, they can become stronger. And the old adage is this: if we don't use it, we lose it. Okay, so that's very important. So again, if we just look at the brain from a neurological standpoint, we've got different areas in the brain. The very front part up in here is called our frontal lobe, and that's really what separates us from animals. That's our higher cortical function, our ability to discern what's an appropriate social situation, our ability to control motion. If I want to move my right arm, my left frontal lobe coordinates with my right cerebellum and help me move that area. My parietal lobe, which is on both areas over here behind the frontal lobe, is our sensation area primarily. So our sensations are felt in our parietal region. So even though the pain is in your feet, you're literally feeling it in your head. That's what that means. Temporal lobe, this area through here are kind of above our ears. That's responsible for hearing. That's responsible for memory. Your occipital lobe is back here in the back, and that's the area that controls basically has a lot to do with where your vision terminates, back here in this occipital region. And then the cerebellum, which is an oxygen hog, it uses more oxygen than any other area of your brain, is located back here at the very bottom. Most people have heard of getting their bell rung. What that means is you've been struck so hard you're basically dizzy and off balance. And the cerebellum is really responsible for controlling those fine motor movements. And it also controls all the postural muscles of your spine. So obviously we see a lot of people that have breakdown in core muscles, or the spinal controlling muscles, and they have weak cerebellums. That's why we have to activate and rehab that area as well. So some common causes of peripheral neuropathy. Number one is statin drugs, okay? Drugs for cholesterol. Spinal issues such as stenosis, disc degeneration, osteoarthritis, even post-cancer treatment or therapy, surgical complications. Alcoholism can cause this. Diabetes can cause this as well. That's a big part, the metabolic aspect of what we do. Autoimmune conditions. An autoimmune condition is where the body is attacking itself and breaking things down. And then there's nutritional deficiencies as well. So how does statins cause peripheral neuropathy? Well, briefly, what they do, folks, is they inhibit the production of what's called coenzyme Q10. And this is responsible for the production of energy in your cell. And when you deplete the energy producers of your cell, that basically leads the cell to cell death. So as a result, we get neuropathy or nerve pain. We can get myopathy, which is muscle pain. We can even get liver inflammation with this as well. And again, the number one use of statin medications is for lowering cholesterol. So again, cancer treatment, CIPN stands for chemotherapy-induced peripheral neuropathy. This is commonly used treatments. These commonly used treatments negatively affect what's called the neuronal cell body, the axonal transport system, the myelin sheath, and the glial support structures. Basically, what these things do is damage the nerve. That's what you need to do. So this connection between here and the rest of the body can't go through as efficiently and properly as it needs to. How does diabetes cause peripheral neuropathy? This is a big one, folks. Fuel supply, again, I can't stress how important fuel supply is. We can't get anywhere in the car if we don't have the proper fuel supply. So if you come to my office and you ask me to treat you for your feet, I have to look at the big picture. Otherwise, we're chasing our circle, our tail in a circle. It just doesn't make sense. So basically, when blood sugar levels are high, when we consume something that has sugar in it, these levels are high over a period of time, it narrows the blood vessels that supply the nerves. So if you can't get blood to the nerves, what's going to happen? Obviously, they're going to become less active, okay? And these blood vessels can also leak compounds in the nerves, which further damages and further fails to provide oxygen to the system. So, as in all peripheral neuropathy cases, again, we have to look at this metabolically as well because it's very important for that kind of case. So again, just another example, insulin carries the sugar across the cell, so an oversupply of sugar fatigues those insulin receptors. The thing with a nerve cell, though, is they don't need a carrier to take it into the cell. That's why often at night peripheral neuropathy can be worse, is because when you lay down at night, there's no muscles or anything that are contracting, there's no muscles activating to contract the blood flow to take the pressure off the nerves. So the nerves really swell at night, which is one of the reasons that pain can be worse in the evening. So how can spinal problems cause peripheral neuropathy? Well, if we look at the spine from the side, we have joints that connect together, and then they have a disc or a pad between the joints, and sometimes they can get narrowed. And when they get narrowed, there's a nerve that passes in between that area, and that nerve can become pressed. Simple way of looking at it is stepping on a garden hose. You can't get as much water out. This is termed foraminal stenosis or spinal stenosis or osteoarthritis. All these things that compromise that nerve root that goes out of the area, whether it's in the neck or in the back and into the leg, can cause problems with peripheral neuropathy. So the treatments mostly that most people get with peripheral neuropathy is they're going to get amitriptyline, which is a sedative. It can cause muscle spasms. It can cause blood pressure issues. It can cause glaucoma to become worse. Antidepressants such as Cymbalta, Wellbutrin, dizziness side effects, migraines. These can cause tremors, all kinds of neurological CNS type things. Anticonvulsants, this is a common one as well. Lyrica and gabapentin. Gabapentin basically just takes your brain. What these things do is take your brain and it works on the GABA neuron or the neurotransmitter and helps decrease overall brain functioning. So what you're doing when you're taking that is you're basically just decreasing and suppressing brain function. Oxycodone, this is respiratory depressants. Folks, what I'm saying is, I'm not saying that drugs are not warranted. Don't get me wrong. What I'm saying is I'm looking for the patients that are focused on trying to correct this and trying to looking for another alternative. If you're completely happy with this kind of treatment that you're getting already, that's not a problem. I'm looking for someone that's interested in correcting the problem and digging a little bit deeper and seeing what they can do to improve their overall well-being. So now that we know this information, what do we do about it? And how do we address this? Well, to find out if you have actual peripheral neuropathy, there's a couple things that we need to do. We need to do a thorough clinical examination. That's very important. We need to get a detailed history as well. We need to send out what's causing your neuropathy. Is it one thing? Is it many? We need to do what's called a Toronto Clinical Scoring Examination, where we put different stimuli in your feet and see which one is causing you to have these kind of problems. So different stimuli, hot, cold, sharp, sharp pain prick, light touch. These are the things that will tell me, number one, how bad it is, which nerve fibers are being affected, and number two, which area of the spinal cord those nerve fibers travel to as well. Once we have that information, then we can properly determine what kind of treatment you may need.